Good afternoon and welcome back to the clinical practices track. I'm getting old.
I see you were laughing.
Today we have Kristina Rogers doing the GPRA overview and updates. Kristina Rogers is an employee of the Nashville Area Indian Health Service and has been with them since October 2005. She is a certified clinical documentation expert for outpatient services, professional coder, biller, and auditor, as well as an AAPC approved instructor. She works as the Nashville Area Statistician, Government Performance and Results Act Coordinator, Health Information Management Consultant, HIPAA Privacy Act Liaison, and is one of the improvement advisors for the Nashville area and provides medical coding and auditing training for federal, tribal, urban organizations nationwide within the service. The session is being recorded.
Welcome, everybody. Glad to be here. I was supposed to put that in person last year, but I had COVID, so I had to do it virtually. So I'm excited to be here without COVID here today. And we're going to go over a different overview. So we'll talk about some general information about GPRA. We'll talk about the local systems, primarily RPMS EHR. Do we have anybody in here that does not use RPMS EHR? Okay, makes it a little easier. We'll talk about the logic. There, you'll see the logic slides. There's a lot of information in there. I'm going to hit the highlights, but I believe you guys will have access to the slides as well. We'll talk about some national system reports, which are the official GPRA reports, and then just some strategies for improvement. Okay. So first, what is GPRA? It stands for the Government Performance and Results Act. It is a federal law that came into fruition during the Clinton administration. During the Bush administration, it was transformed again to have more budgetary strings. And essentially what it does is it asks for a data supported audit trail for how the funds that we're given reach our patients and the outcomes for our patients. So they want to know, we're giving you money, what are you doing with it, and how is it impacting our customers? Next slide. Under the Obama administration, it was transformed again to what is known as the GPRA Modernization Act, GPRA-MA. So you may hear the term GPRA and GPRA-MA used interchangeably. They're similar, but they are different. Under Obama, it basically is strengthened the original law to make it where federal agencies have to use performance data to drive their decision making. Next slide. So what it also did is it decreased the number of measures that get reported to Congress on an annual basis. So prior to the GPRA-MA Act being put in place, the agency would report anywhere from 20 to 26 measures to Congress on an annual basis. That's a lot. So what we did, they limited it to 2 for 2023. So the intimate partner violence, domestic violence screening, and influenza for the 18 and older are the measures for 23 and actually 24, 25, and 26 that'll be reported to Congress from the agency. The rest of the measures, because every year it fluctuates between 20 and 26, next slide, become budget measures. So just as important, because what they do is we can use those to say, hey, we've been spending this money on treating our patients. We have really great diabetes rates, or our screening rates for colorectal cancer that's through the roof. Our patients are getting these services. Is there any way that you can use more funding? So these budget measures come into play as well, because we can use them as an agency to request more funds. It doesn't always happen, but it doesn't hurt to ask. Next slide. So why is GPRA important? So if you are from a federal program or an urban program, you're required to report for GPRA. If you're from a tribal program, which most of you are, you're not required to. But we thank you for participating because it can impact the overall budget for the agency and the funding that comes down to the area and to you guys. So tribal sites, you're not required to report. We have, I believe, all of our tribal sites in the Nashville area participate. So we thank you for that. That is not the case in other areas. So keep up the good work. GPRA can also allow for better patient care. So As we go through the measures, you can see, you might see, they're considered a minimum standard of care. There's different age buckets for different measures. A lot of them are screening or prevention measures. So these are things that at a minimum our patients should be receiving. Things like dental services, things like pap smears, colorectal cancer screenings, screening for depression. These are just like minimum basic things that people should be getting when they come for services. GPRA is also a way where you can see if the services that are being done are being put in the right spot in the EHR, because things have to be in structured field data areas in order to count. If it's just generic provider's note, it doesn't count. System can't search notes. It has to look for specific data points. So you can use GPRA to say, if last week, you did 25 pap smears and doctor says they put it in, you could actually go in and say, it's not showing up, or great, it's there. And that's a teachable moment, because you can get with them and say, you might need to put it in these other places to make sure that you're getting credit for it. And then overall, we hope that because there are minimum standards of care, it could potentially improve patients, so we catch cancers that we might have missed earlier. And we hope that it decreases the cost of caring for patients, which helps our PRC budgets. So we can catch them on the front end, makes the back end a little cheaper. Next slide. So how is GPRA measured? And if you have questions, shout out. I'm probably going to try to go through it pretty quickly, just for time. So essentially, the agency looks to see for areas of emerging concern for our population. The Office of Management and Budget ultimately makes changes because it's tied to funding, right? So if they're wanting to know a specific thing, then that's what we report to them, hence the domestic violence, intimate partner violence, and influenza. But there are some what we call developmental or non-national measures that get built into the system. If anybody's ever run a CRS report, you know that there are lots of options. Not all of them are reported to Congress or as part of the national official reports. They're what we call as developmental. So for instance, there's measures on, I think there's a measure on obesity that is not reported, but we can pull the information out in a canned way, just as an example. Next slide. So there's 4 different buckets: diabetes, dental, immunization, and prevention. The biggest bucket is the prevention measures. And I'll go through these later in this slide set. Next slide. So the local system reports. All right, so these are ones that you want to use for quality improvement purposes and improving your workflow, seeing patients, the outreach, those types of things. The CRS, the clinical reporting system, it is a package in the RPMS, the roll and scroll, not the point and click. And it is standardized for everybody that uses RPMS EHR. It's the same in our sites versus the California's bad because they don't use it, but like the Phoenix sites, it's the same everywhere. It has benchmarks built in, updated on an annual basis, same logic. So it's nice because you can run it and know that you're kind of on the same level. Next slide. And each measure has a numerator and denominator. And wherever possible, the agency tries to use industry standard codes. So ICD-10, SNOMED, Link codes. There are some IHS standard codes that are not part of other COPS products, like health factors and patient education codes. So that's why I wanted to see if there was anybody not using our PMS, because there's some of the measures are more difficult to meet if you're not on the system that's supported by the agency. So essentially what the package does is it does a scavenger hunt. It looks to see, is the patient eligible for service? If yes, do they have the service? And so it basically just does, it adds into the numerator and denominator, and it does a percentage to see how many of those people meet the measure. There are some taxonomies that it looks at, and a taxonomy is basically just a grouping of like items. So it's looking for specific labs. The community is your service delivery area that's built into the RPMS system, and then for medications as well. Next slide. So I always like to put this disclaimer up here, because software is just that, it's software. It's not a magic thing that's gonna make things better. It can make things easier, it can make things harder. But whatever you put into the system is what we're gonna be able to pull out of the system. So just with my example with the pap smears, if people are putting things in the wrong spot, then we can't pull it out and you won't get any credit for that. So where things go in the system are very important as well. Next slide.
Hey, Kristina, I just have a question, like on that path,
Yeah.
like if they put a path as part of the procedure code in court.
Yes, so if they're put it in, if they do it on site, you put in the super bill,
Right.
it counts. If they don't do it on site, you put it as a historical service.
Correct.
It counts as well. Only caveat to that though, if the outside service was, say, the HPV DNA, because that's a 3 years, when you do the historical services, it's only gonna count it for 1 year. So there's a few little nuances. Okay, next slide. So in order to meet the GPRA measures, it takes the whole team. You can't dump this on a nurse, you can't dump it on a provider. Everybody is involved, from the registration folks all the way to the providers. The registration folks, it comes into play because they are listing where people live. The community taxonomy, that's a big deal because GPRA only counts people that live in your service area. So if they're putting people in there that maybe shouldn't be, or they're putting them in as American Indian Alaska Native, maybe they actually aren't, those can impact the numbers. And so it is important that our staff understand that no matter where they are in the line of patient in to patient out, it really can impact these different numbers. So of course, the providers are going to be providing the services. That includes nursing staff, MAs, anybody who touches the patient. And it varies per clinic as to who does what. So some places have nursing staff doing triage and entering some of the screening information. Some places have a centralized screening area where they get all the screenings and then they get farmed out to whatever specialty, whether it's medical or dental. Some places have the providers doing all that. So you'll have to figure out what works best for your site with your staffing, with your workflow, to figure out what would work best to get some of these items met. Coders are going to be coding the visits, entering information. You can use health summaries, CRS patient list, forecast report. I don't have iCare on here, and that's because sometimes this presentation includes non-RPM slides, but iCare is a great tool as well. The difference between iCare and any of the CRS reports is the time frame. So sometimes somebody will show meeting on iCare, but not in CRS, because iCare goes back 365 days from the day you pull it. CRS is always the fiscal year. So just keep that in mind, depending on what you're using. Next slide. So these next few slides are just some screenshots of some of the tools in the system. So this first one is a patient list. So if, say, you wanted to do some targeted outreach, say it is, March is colorectal cancer screening month. So if you wanted to see who needs a colorectal cancer screening, you can pull a list of patients, say in February or even January, and you can do outreach. You'll have a list of people that need the service, and you can say, hey, come in, we'll schedule you for a colonoscopy. So this is good if you're doing any targeted condition-specific outreach. Next slide. The forecast report is next. And this is one of my favorite ones. You can pull it by clinic, by appointments, by the whole facility, or kind of ad hoc as patients come in. Next slide. And basically what it is, it's a list. So it says this patient came in and they need all these services still. So it's the perfect opportunity, depending on what it is, like in this case, it still need some of the screenings, right? So perfect opportunity to ask them these screening questions while they're here. They may be coming in for a sprained ankle, but they may not come back. So it's a good tool. The other one that some people use, which I don't have it on here because it's broken, I will say that, is the reminders. Reminders are also a good thing that people can use. I will tell you that they're very outdated and old right now, but we keep hearing that they're supposed to update that pretty soon. Right now, the logic is still from 2017. So if you are using reminders and it's still not turning people off, that's why. All right. So next, I'm gonna kind of fly through some of the logic stuff. I'm gonna hit the highlights, but again, you will have access to all of this information. So next slide. So for 2023, and I will tell you, so 2023 is 25 measures. For 2024, it's gonna go up to 26. And I'll mention which one it'll be as we go through these. But there's 3 dental, 5 diabetes, 4 immunization, and then 13 prevention related ones. We are also tracking some non-national, those developmental ones that kind of feed into these national measures, and I'll mention those as well. So next slide. All right, so one big change from last year to this year is how the user population is calculated in the CRS package. So there was a new release of the CRS package last week, actually, so it hasn't probably been installed on anybody's site yet. But what it does is it mirrors the user population calculation at IPSIS, which is the integrated data collection system, which is where the official GPRA reports are created. That logic looks at patients that had 1 visit in the last 3 years, who live in your service delivery area. And the visit is either telemedicine or ambulatory. Currently, without this new patch, the CRS user population only looks at patients that had an ambulatory visit. So if you're looking at the reports that we send and notice that the denominator numerators are different for RPMS and IPSIS, that's part of the reason, is because IPSIS is counting people who just had telemedicine visits, but RPMS is not. That's not to say that they will start to match exactly. They'll be closer. But there are some nuances that go into user population and area-wide duplication that can't be replicated on a local system. So. All right, so dental measures are first. So we're looking for access to dental. And this is just to say, anybody who is part of our population, did they have a dental visit? Dental sealants is ages 2 to 15. If they had a intact dental sealant, if you have dental programs and they are seeing patients that don't need sealants, there's a code 0007 that they can use that basically says, I checked, they don't need them, we're good. And you still get credit for that. Topical fluoride, this is patients 1 to 15. If you don't have a dental program, this is a service that could be done on the medical side if properly trained. So there are some trainings available through the IHS that can orient medical staff to doing the topical fluorides if you don't have a dental program. Next, we have diabetes. So for the main thing with this one is GPRA year starts October 1 to September 30th. If a patient is diagnosed with diabetes on October 2nd, they will not show up in this denominator until next year. So they have to have diabetes diagnosed prior to the start of the GPRA year. That one throws a lot of people off. Essentially, for blood pressure, we're looking for controlled blood pressure, 140/90. It's got to be both the diastolic and systolic values below that count in order to count. Question, yeah.
So can you repeat what you just said about the diabetes?
Yeah, so in order for them to be part of the GPRA diabetes, now remember GPRA and diabetes audit are different. So the diabetes audit, you decide who's your active diabetes, right?
Okay, yeah,
So
okay.
this is looking strictly at a diagnosis code. Whether you consider them active or not.
So it goes October 1 of the previous year.
October 1, so for 2023, the GPRA year is October 1, 22 to September 30th, 23. And so if you have a patient who's newly diabetic or new to your system diabetic, they could have had diabetes for the last 5 years, but they're a new patient to you. It'll calculate them based on that first diagnosis in our system.
Okay. And then you had mentioned the blood pressure. Isn't the new quality measure supposed to be 130/80? Or are you sticking with the 140/90? I'm confused.
I will tell you, our measures are typically couple of years behind with new clinical standards.
Okay, okay,
Eventually it'll be that, but right now it's still a 140/90.
okay, thank you.
And so that happens a lot with, so mammogram is one that changes very frequently in the age and the frequency. Typically our agency is a couple years behind in terms of adopting any new clinical standards. Okay, so nephropathy assessment, we're looking for a GFR and a urine to albumin creatinine ratio. They don't have to be on the same day, they just need to be done during the year. Because I know a lot of patients maybe can't produce urine at their visit, but you can take blood, right? Okay, next one. The glycemic control measure. So this one, we're looking at patients that are in poor control. So we want this to be as close to 0 as possible because it's A1C greater than 9. Retinopathy assessment, we're looking for diabetic retinal exam. If anybody's interested in looking in the JVN machine program, it's a lot better now. It's easier to do. The requirements are less. It used to be a big pain because you used to have a certain number of patients to go through the system in order to keep the machine calibrated correctly. It's a different machine. It's a lot better to use. So if that's something that you guys might be interested in, let me know and I can send you information about it. Next slide. The statin therapy for those diabetic patients, it's basically just looking to see if patients are on statins. If your patients are not able to be on a statin medication, you want to document that as a contraindication, because what it does is it takes them out of the denominator. So they're not part of it if they can't, their bodies can't handle it. Next slide. Immunizations. So the adult immunization measure for 2023 is a baseline measure, which basically means whatever you get, you meet the measure. The reason it's a baseline measure is because the age buckets change. Excuse me. And then the Shingrix. So we took out the Zostavax. So the 19 to 50 is the Tdap TD in the past 10 years or one Tdap ever. I will tell you that that's probably the easiest age bucket to meet because it's only 2 vaccines, right? As we get older, there's more that we need. So the 51 to 65 is both of those plus the 2 doses of Shingrix. That's typically a hard one to get because people don't come back for that second one, right? Yeah, right. So it's harder to beat that one. The 66 and older, it's all of those plus a up-to-date pneumococcal vaccine. And it's an all or nothing. So if you are of that age group, you have to have all those vaccines in order to show us meeting that measure. Next slide. Childhood immunization is very similar. This one's been around longer, but again, it's an all or nothing. And typically it's those series shots that get us. If you have a child that maybe gets off schedule, they won't ever show up as meeting the measure.
That's awful.
Yeah, it's terrible. And we've asked about that and they won't change it. So try to keep your kids on schedule because if they get off and even if they get the rest of the vaccines, they'll still be showing as not meeting it. Influenza, it's basically everybody 6 months and older, just to make sure that they have one yet, Brian.
With the childhood immunizations, if you go on the state registry and they have the vaccine out offsite in a timely manner, it still counts if you enter it historically with that date.
Yeah, so absolutely. And if anybody has access to your state registry, or if you don't have access to it, you want to work on getting access because especially for the childhood immunization, that is gold. Because a lot of our sites don't have pediatricians. So they're going to an outside pediatrician and you can get that information and enter it into our system and still get credit for it.
Are you speaking of Impact? That's the registry.
Maybe what state are you
That's for
Maine.
Maine.
It's for Maine.
Yeah, that's
Yeah.
for Maine.
So
Oh, is it just for Maine? I didn't know that. Sorry.
State is different. Unfortunately and unfortunately, we have 14 states. So, but yes, it would be access to that. So you can go in. And some state registries have adult immunizations. I know New York does, but there's a special release that you have to get from them to access it. But not all states do adult register as well. So cervical cancer is next. This is female users, it's looking to see if they had a pap smear in the last 3 years or 5 years, depending on what service they had. And this is where I was mentioning to Nancy that if you use the historical procedures in the system, it only captures it for that 1 year. Even if they had, say, the HPV DNA, which is a 5-year, so it's kind of a pain, kind of a prompt, I guess. The childhood weight control measure. So this is going to be the new measure for 2024. I say new, it's not new, but we as an agency only report it every 3 years because it's a long-term goal. And it's another one that we want to be as close to 0 as possible because it's looking at patients with a BMI at or above the 95th percentile. Colorectal cancer screening, last year they changed the age range from 45 to 75. This is another example of that it took us a little while to catch up because it had been that standard probably for 2 or 3 years, and then we finally changed the age. Next slide. Controlling blood pressure for 1 million parts, just like the diabetes one, it's just a larger group of patients. Next. Statin therapy, same deal, just like the diabetes one, but a larger group of patients. Depression screening, 2 groups, the 12 to 17 and the 18 and older. So right now, the PHQ-2, 9, and T is the recommended way to screen for this. In 2024, the PHQ-2 is going to be removed from the logic. The reason is because CMS is no longer recognizing it as a appropriate screening tool. So if you are only using the PHQ-2, we need you to start using the PHQ-9. Or you can also document it under the wellness tab under exams for depression screening right now. That's acceptable as well. For the breastfeeding, most of our sites don't see babies, right? So you might see them at 6 months or 8 months. We can still enter how they are being fed into the system, but it has to be done through the roll and scroll side and not the EHR side. So if you have babies or are interested in that, we have some instructions that we can share with you. Because if you put it in through the EHR side, it's gonna be like today's visit, how they're screened today versus how they were when they were 2 months old. HIV screening over 13 to 64. At this point, we're just looking to see have they ever been screened for HIV. So that's another reason why I say this is a minimum standard of care.
I have a question on the breastfeeding. They do a lot of the education and help the mothers at birth in the hospital. Can we, if we're paying for that, can we collect that data?
You can. Yep, you absolutely can, even if you're not paying for it. Because I'm not a mom, but I assume most moms know how they were feeding their baby at 2 months, right? So even if they come in at a 6-month visit, you can still enter it historically as to how they were being fed at 2 months and get credit there. Yeah.
Excuse me, when you're saying you can't add it to the EMR, where are we adding it to?
So there, I believe it's under, Brian, you may have to help me out with this one. Is it under the triage tab? I think there's an infant feeding.
There is.
Yeah, so if you use that infant feeding option in the EHR, you can't backdate it. So it's just the day that they're there. If they're there when they're 2 months, then it's perfect. But you're probably not going to see them at 2 months. You're probably going to see them at 6 months, 8 months. So that's why we also want to do that historical entry in the PCC side, or the RTMS roll and scroll side, so that you do get credit for it. We kind of trick the system.
You can't backdate in the EHR.
But on the back end, you can't.
Yeah.
Okay, so intimate partner violence, this is one of those GPRA measures. Right now, we are only looking at female patients that are 14 to 46. Also why GPRA is considered a minimum standard of care, because we know males experience domestic violence as well, outside of older than 46 and younger than 14, also experience that. But for the measure specifically, we're looking at 14 to 46. But we do recommend every patient, every visit, at least every 3 months, because life happens. I could be great today, something could happen tomorrow, and I might need help next time I'm visiting you. The mammograms next, and it's looking to see if patients 52 to 74 had a mammogram in the last 2 years. And it doesn't count historical entries. So if you're paying for it through PRC, you want to make sure that your PRC folks are closing the purchase orders with ICD-10 codes and CPT codes. If they do that and you guys pay for it, it'll count for this. You can also enter the information historically as well, and that counts. Alcohol screening is next, and this is patients that are 90 to 75. The recommended way to document this is use the cage factor. Or the audit SEER craft. There is an option in the wellness tab to use the exam code for alcohol screening. That is not recommended because the result of that does not get sent to the data center. And we have seen sites meet it on the local system, but not at the data center because they were just putting it under that wellness tab as an exam. So if you're just doing that, you can continue that, but I would add in cage audit SEER craft. The reason why that's important, no, you're fine, Brian. The reason why that's important is because it feeds the screening, brief intervention, and referral to treatment measure, that SBIRT measure. This is also a baseline measure for this year. And so no matter what you get, you're gonna meet it. This one has the caveat that actually there should have been. So a couple things that changed, ambulatory or telemedicine. I missed that in here, I'm updating this. So ambulatory or telemedicine visit 7 days after that positive screening. So patient comes in, they screen positive for alcohol use. We need to either refer them to treatment or provide education and then refer them to treatment within 7 days of their visit. If you're outside that 7 days, then they won't meet it. They'll have to be rescreened and kind of start the clock again. Next slide. So tobacco is next. We want to screen everybody 5 and older. If they're positive for tobacco use, even electronic nicotine devices, we want to provide them with the patient on quitting or some type of medication for cessation. All right, I'm going to stop real quick and see if there's any other questions because I went through that really fast and I apologize. Yeah.
Do you know if the nursing bundle is gonna get updated with the depression?
Yes, but we don't know when it's going to be released. So for those of you that don't know what it is, so there is a screening bundle that encompasses a lot of this information. The last time it was updated might have been 2015. And it hasn't been updated since. So that's another one. When the reminders come out, I think the screening bundle will come out. We just don't know when that'll happen. So.
Kristina, on the alcohol, when you said 7 days, you also said and a referral to a program?
So,
And where is that documented?
yeah, so at a minimum, you want to make sure you're providing education, but typically what happens is the alcohol screening is done on the medical side, right? So typically, there's going to be a referral to behavioral health. So if they screen positive, on the medical side, the recommendation is to provide just brief education. Now, one caveat that I didn't mention with that is there's only 2 education codes that count for that. Under the alcohol and other drugs, it's the treatment and brief negotiated intervention. If you pull that list up, there's lots of other ones you can choose, but they won't count for this. So recommendation is screen. If they're positive, provide education, and then refer them to behavioral health for treatment. So the referral, depending on if you have behavioral health in-house, it's either going to be as a consult, an in-house consult to another department, or as a referral if you have to send them out for somebody. Other questions on any of what I've covered so far? I know it's a lot. Okay, so I'm just going to kind of fly through these ones, but it is good for you guys to know the difference, which is why I add these in. So the National Data Warehouse is where data from your local RPMS system gets sent. It's a national repository. It is separated into different data marts. This is where your user population, workload, and then now GPRA is calculated. Next slide. Essentially, the reason we went to having the integrated data collection system, also known as ITSIS, so you may hear that term. We moved to reporting out of this system nationally because we had a lot of sites get off our PMS. It used to be that the only way you could report for GPRA is if you use ARPANET CHR. Well, we had a bunch of sites nationwide get off, and so this allowed them to still participate with the reporting. Next slide. So the results are only as updated as the last export. So everybody in here has an export that is set up to go on an automatic basis on the 21st of every month. There's a few larger sites that it goes on the 8th of the month as well. So when we send those updates to you guys, typically towards the end of the month, they're old, right? Because they're only through the 8th or the 21st, and we usually don't get the updates until sometime between the 20th and 30th. But even if the data is exported on the 21st, it takes 8 days for it to get loaded into the system and updated. So when you see those ITSIS reports, it's always delayed until the end of the year. But the RPMS reports are real time. So the official reports use the official user population, which again is the one visit in the last 3 years, live in your service delivery area, and then our American and Alaska Native. And then it follows the fiscal year. And we covered that one. Go ahead. So this is important. Export deadlines. So if you want your data to count for 2023, you need to make sure all 23 data is in your system, complete, accurate by the 25th of October. That is the deadline for exporting data to the data warehouse for GPRA user population to work with. So some things are still working out. So right now the ITSIS data is still using the 2022 logic. They won't update that until October. So we have no clue what you're gonna look like. But we have an idea, because usually by the end of the year, the RPMS data matches the ITSIS data pretty good. If you are from a place that has a shared per code, do we have anybody in here from Maine sites? Yeah, Maine sites, Connecticut. They haven't been able to separate out GPRA data by facility yet, so it's still by service unit. So when we send those reports, what we have done is we're able to use your user population sharing agreement percentage and apply that to the numerator denominator. So at least what you're getting is your portion. It may not necessarily be your patients, but it's your portion of that denominator and numerator that is available. It's not perfect, but it's what we got. And then I don't think we have any urban programs in here, but they're trying to figure out the urban program user population because they don't have service areas like tribes do. So that's something that they're still trying to work out. So all that to say, for you guys on the local level, nothing changes. You're still going to be seeing patients, still going to be documenting in the system, cleaning up your error reports. Nothing changes in terms of that. Just know that there are some nuances and differences between the two reports, which is why we like to try to send both of them to you guys. Next. Yeah, so we do send reports, like I said, usually around the 20 something of the month. This kind of depends on our schedule. Yeah, go ahead. All right, so just some strategies for improvement. These are things that we've learned over the years. You want to make sure that you are entering medical data for outside services. So if you're doing referrals, if you're doing PRC services, and you are actually paying for those visits, when you are closing those visits, again, you want to make sure you're putting ICD-10 codes, CPT codes in. If you don't, when you close the purchase order, then you have to go back in and enter it anyways, if you want to get credit. If you did a referral for a patient and you were not paying it out of a purchase order or PRC. If you're able to get those reports back, say the patient has insurance, right? So you're not paying anything out of PRC. If you get those reports back, you can still enter it historically into the system and get credit for it, even though you didn't do it. But you're still following up with that patient and updating their record. So these are things that are not done on site. Anything that's not done on site, if it's clinically relevant, should be entered back into the EHR. Next slide. I think I just mentioned that, but we do have some cheat sheets if that we can share if you have new staff that aren't real sure how to enter that information. You can also do trainings on how to enter that historical information as well. Next slide. That's just some screenshots of cheat sheets. So one thing that we do have visual representation and then just the words for where to put things in the EHR. We have one for RPMS sites and non-RPMS sites. And then we have some instructions on how to use the back end, the roll and scroll side. Next slide. So the historical data for most sites is going to be your bread and butter. Because you're probably going to be sending a lot of patients out for services, and you want to make sure that you're getting that stuff back and into your system. Because even if you don't provide the care, you can still get credit for it. Next slide. We also have some recorded trainings. Some places have started to use these to orient new staff. They're little short snippets, I guess, about how and where to document in the EHR specific to each topic. So there's some on just some general information on GPRA, something related to diabetes, dental, cancer, behavioral health. So some places have started to use these for new employee orientation. You want to make GPRA a priority. Align it with your organizational mission and goals. Check your data regularly. We're running the reports, we're looking at them, and they could look amazing to me, but I have no idea what's happening on the front line. So if it feels wrong, or if you know that you put in 200 flu shots and it's only showing 3,
Oh,
we can do some sleuthing and figure out, are people putting it in the right spot? Are they just putting it in a note? Let us know, because we can help you troubleshoot and figure out what is going on. You want to look at opportunities for improvement, run those patient lists, and use a team approach. Some places will do weekly or monthly huddles. Some places do daily huddles to kind of look and see, these patients are coming in, these are the services they need. Let's make sure they get these referrals, or ask if they want referrals. Let's make sure they get these screenings. You want to coordinate between providers and divvy up those roles and responsibilities. As I mentioned in the beginning, this cannot be done by one person. This cannot be done by 2 people. It takes the whole team, from the moment the patient steps in the door to the time that they step out and those claims go out the door. Identify patients who need services, use tools that can help you identify them. You want to max pack visits. I'm one of those bad patients that I only come when I'm sick. I think I got a physical for the first time in 10 years last fall.
No better.
I know. Well, and so what they did is they asked me a million questions because I had to come in. But when I come for a sick visit, they don't ask me those questions, right? So, but I can guarantee I came in at least once every year because I was sick. But they didn't ask those questions until I came in for a physical. So you want to build it into your workflow where no matter what the patient is there for, you ask them the screening questions, you see if they want referrals. And yeah, they're not going to be feeling good. They may not say, yeah, I want to schedule my mammogram. But you can ask. And you might get those few patients that are like, yeah, I'll go ahead and schedule it. I'll feel better in 2 months. We'll figure it out. So you want to make sure that while they're there, you provide them all the services that are appropriate at that time. Some places will send out postcards or letters inviting them to healthcare, dental programs, those types of things. And then you want to make sure that you're following up on test results. Sometimes our reference lab links break, right? And we have to enter things manually. Or patients are they have an endocrinologist outside of your system. You want to make sure you're getting those lab results back to put them into your EHR, not only for GPRA, but also so that your providers can make informed decisions about the care that those patients are getting. Next slide. So I did want to just give you guys a preview of how we're looking as an area. And these are a little bit old, because I had to get the slides in. So this is from 7/19. So we have met the topical fluoride, the controlled blood pressure, nephropathy, portal control, and statin therapy for the dental. We're doing pretty terrible on the immunizations. I will tell you, there's probably a handful of sites that have actually met the influenza this year. Immunizations were tough because people were tired of getting shot, right? So hopefully this coming fall, that'll change. And I believe, I was actually talking to Robin about this. I believe the guidance is you can give both COVID boosters, supposed to come out with boosters. in the fall. Booster and flu, the same visit, if the patient is willing.
So they're going to do COVID boosters again?
Yeah.
Because last time I went, they said no.
I talked to Robin last week and she said they're supposed to come out with a booster in the fall.
Okay.
But the COVID is not a mandatory.
COVID's not mandatory, but the flu is. I mean, it's not mandatory in terms of reporting. If you're a federal employee, it's mandatory. So we have also met, because these are. Oh, you know what? So the other thing, they have not updated on it says the targets. So it's still looking at the 2022 targets. So we have not yet met this, even though it says baseline. We have met colorectal cancer screening, the million hearts measure, statin therapy, the depression measures we've met, HIV ever and intimate partner violence screening, expert measure, and then the alcohol. So we're doing pretty well. So that says 15 measures, but I just ran reports yesterday and pulled the data, and we're actually up to 18. So the national area has always done really good because you guys care. If we just relied on our 3 federal, well, now 4 federal sites, our area would not look this good because it still would include the whole population for the natural area, right? So you guys, your tribal sites, the fact that your staff and patient and staff and employees care really helps our area. So again, we thank you guys for participating and being active in it. So the 2024 targets are listed here. They're pretty much the same. Thankfully, they haven't increased. I will tell you that a few of them did increase this year, but a lot of them decreased this year because those targets are based off of the previous year. So 2021 was a pretty terrible year for GPRA as well as 20. So the targets went down for a lot of them. Next slide. All right, questions?